The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
On this panel of discussants is Dr.
Prisca Ogbuogebe
and my humble self, Dr. Nwala Gabriel. So just sit back. As always, we promise to bring you industry insightful topics and presentations that will help improve our practices in our respective hospitals. So this is who we are, and we are a multi-specialty hospital with all the different subspecialties from general pediatrics to neonatology, neurology, cardiology, adolescent medicine, and so forth. So the vision to keep providing world-class patient-centered care with the contemporary state-of-the-art facilities and professionals. Since 1982, Limi Children's Hospital has been in Abuja, ensuring that our children are happy, because we believe that a happy child makes a happy home. So if we are able to make these children happy, families in Abuja will be happy as well. So straight to the topic. Before we proceed, I want to share some housekeeping formalities for us. Please, if you have any comments or questions, just put it on the chat box, and we will be looking at them as the presentations goes on. So traumatic brain injury, Dr. Prisca.
Okay, good afternoon, everybody. Today we're presenting traumatic brain injury in children. We'll be discussing the good, the not so serious, the serious traumatic brain injuries, and the emergent or life-threatening traumatic brain injuries. Myself and Dr. Nwala will present soon.
Okay, so it's our firm belief that by the end of this presentation, we should be able to have a heightened suspicion of the potential life-threatening nature of traumatic brain injuries when they present to us. And, we should also be able to identify some red flags, that will tell us traumatic brain injuries that are severe, the ones that you really need to do something before the child, tilts over to the other side. and knowing that traumatic brain injury is something that can happen, and people, children that can present to us, and the red flags. What else? How do you manage when they present? So if by the end of this presentation we're able to achieve these 3 major objectives, we'll be happy. So to our case scenarios.
Okay, so we'll be discussing 3 case scenarios that will be able to encompass our topic, the good, the bad, the ugly. Case number 1 shows the good. A 1-year-old child was rushed into the facility following a fall from her cot. Baby cried after the fall, but consolably. There were no seizures, no loss of consciousness or bleeding from any orifice. She had no neurologic sequelae on examination. Routine investigations were essentially normal. Patients were assured and child was allowed to go home after 6 hours of observation. So this shows the good. It was a traumatic brain injury, but a not so serious one.
So the second case scenario was an 8-year-old male that was playing, in his room with a bed, those ancient beds with very strong iron frames. So while playing, he fell the back of the head onto the hospital aspect of the scalp, and had some headaches thereafter. So initially, he took paracetamol and thought that would be enough. The mother actually gave him that, and some days after, the headaches were still there, and in fact worsened in severity, warranting their presentation to our facility. So physical findings just revealed mild tenderness over the hospital area. There was no crepitus, no defects, and other physical findings were essentially normal. Just to ensure that there is nothing untoward, going underneath this skull, a cranial CT was done, which revealed the normal study. With the worsening nature of the headaches, they presented some days later and were referred to see a neurosurgeon for possible repeat brain imaging and further expert care. So this was bad because there could have been a concussion or a contusion. So that now takes us to the ugly scenario.
So AL was a 13-month-old poorly supervised female that fell off the balcony of a 2-story building. She fell on the left temporal parietal aspect of her scalp. She had epistaxis, erythemus patch over both her eyelids and her left ear. There was a right-sided focal seizure, which was noted later to be bilateral, and the child later lapsed into unconsciousness. She was admitted into the ICU and she spent 15 days there. She had 3 neurosurgical procedures, including a shunt and a craniotomy, and received IV fluids, antibiotics, and respiratory support. However, following good clinical response, recovery of consciousness, tolerating orally, child had her sutures removed. She had some neurologic sequelae for which physiotherapy is being offered.
Okay, so the 3 procedures that were done for the child, one was she had a decompressed skull fracture that was relieved, had washout because there were some direct injury to the parietal aspect of the left side of the head, which had to be, debrided and all. Then the wound was explored some days later. So when the place was clear, a shunt was passed. So those were the 3 neurosurgical procedures that were done for the child. The child recovered consciousness, but had hemiparesis on the right. This happened on the left. So there was affectation of the right upper and lower, right upper and lower limbs. The child couldn't move those parts. So physiotherapy was being offered, and the child is doing well. So this tells us that traumatic brain injury can be something that we shouldn't, bet an eyelid over. It can also be as bad as this 13 months, not 13-year-old, 13-month-old child, that fell off a high-rise building. So that brings us to TBI. Okay, as has been our practice here, we would have wanted to ask us, okay, what we talked about, the first, second, and third case scenarios, which one we thought was mild, which one we thought was moderate, which one we thought was, severe. But we've given expose, so will not bother us with that. So if you have any questions or comments, you can, send them in on the chat box while we continue with the presentation. So, Dr. Prisca.
Okay, so traumatic brain injury. It is a condition where there is a disruption in the brain's normal function, usually caused by a mechanical impact on the head. It is a significant contributor to mortality and disability amongst children aged 1 to 18, and incidence is about 180 per 100,000 children annually in children aged 1 to 15 years old. So it is the common causes of traumatic brain injury include falls, especially in toddlers, like our case number 1 and 2 and 3. All 3 cases were caused by falls. Motor vehicle accidents, they can cause traumatic brain injuries. Sports and recreational injuries. Most children are enrolled in many sports activities like football. A ball could hit their head, or they are running and they fall down. It could cause a traumatic brain injury. And non-accidental trauma, notably in infants.
And usually, when you find a child with a non-traumatic trauma, don't always think that it's accidental. Child abuse will, happen. Somebody might beat up a child to use another. You see in one of the pictures we have in the subsequent slide, where a caregiver actually, while beating up the child, a stick does stop into this, head and all that. So don't always believe that every traumatic injury was, accidental. It can also follow child abuse. So why are children, usually at risk? One would say, if there is road traffic accidents, it's not only children that will be in the vehicle. The parents will be in the vehicle as well as the children. Like the case that happened not so most recently, where some of these taxis were pursuing a man around Barnes area. So as the man was trying to run away from them, fell off the bridge, and 3 of them died. So traumatic brain injury is not something that will not affect adults as well. But there's a reason why children are more at risk. The reason, if you look at the developmental and anatomical factors, you will find that the ratio of the head to the body, you find that the head size, if you compare the head size to the body size of infants, toddlers, you see that is actually bigger. So when they fall, there is a higher tendency that the head to be head first kind of fall, and the traumatic brain injury will happen. Compared to adults, adults will have limbs, both the upper and lower limbs, all over the place. So when they fall, they can stretch out their hand and they have the hair, cushion the effect of they fall on the head, or fall on the leg. There might be fracture in any of those places, trying to protect the head. Or when it comes to a child, the size of the hand and and the upper limb and the lower limbs are actually smaller compared to the size of the head. So they are more, there's a higher tendency for them to fall on the head and have a traumatic brain injury. The the other reason why children are more at risk, is actually the diagnostic challenges. Most of the symptoms may be there, but a toddler may not tell you, Mommy, I'm having headache, or Daddy, I'm having headache. The symptoms, because of the presence of the fontanelles and all that, even if there is intracranial hemorrhage, there's enough space, provided by the presence of those windows, fontanelles, for the blood to be collecting and expanding into, unlike adults or older ones, that the skull is just a very constricted area that will not allow for that luxury. So the symptoms in younger children may be delayed because of that, and most of them don't talk. They may not know how to describe confusion, dizziness. The child might just be crying, like the first case scenario. They cry, you may not know what is causing the cry. Most times when children cry, it'll be like that, oh yeah, come and solve Bobby or something. Meanwhile, there might be something else that might be going on. So those are some of the reasons why they have more reasons. The other factors,
behavioral or environmental risk. Children lack judgment. If they have limited judgment, especially during play, sports, exploration. If you've ever been with a child, you will see them, they are trying to jump out of a swing or jump from a balcony. They have limited judgment. And then also non-accidental traumas. Infants are vulnerable, especially like we discussed, to abuse-related head injuries, like the shaking baby syndrome, which can be an example can be seen in the picture there.
So you can see from here, most parents have the habit of, when their babies are crying, they will want to, try to console the child by shaking. Some want to throw the child up and catch and all that. So when you do that, see these three areas. You can see here, as the head is going backwards, the brain is hitting the skull, the inner part of the skull. At this point, there could be an injury there. When you shake it towards the front, there could be an injury at this point. Even the to and fro movement and all that can also impact negative that the cervical vertebral area. So these are potential causes of concussion and all that, contusion and all, which are presentations you find with traumatic brain injury. So non-accidentally, parents can inflict this kind of injuries on their babies. So the symptoms
of traumatic brain injury, they differ by age group. All age groups or general symptoms could include the loss of consciousness, confusion, or disorientation. Some children might start having headache, vomiting, or be feeling drowsy. There could be amnesia, as anterograde or retrograde. Anterograde, they can not remember anything happens after the injury, or retrograde, they can't remember what happened before the injury. Seizures or altered mental status, the irritability or agitation, like our first case scenario where the child was crying, could be that the child was being irritable, scalp swelling or bleeding from ears or nose, which was seen in our third case scenario, focal neurologic deficits, weakness, unequal pupils, cranial nerve palsy, which was also seen in our third case scenario too. In infants and young children, following a traumatic brain injury, we can note irritability and inconsolable crying, like I've said, poor feeding or refusal to feed. The child is not feeding as usual, or you try to give them food. Because of that irritability, they can't express what they are feeling. So these are the ways we can tell that something is wrong. A bulging fontanelle in younger children, increasing head circumference, which suggests raised intracranial pressure, high-pitched cry, altered level of alertness. They are less responsive, they are floppy, they are just not as they were before, seizures or abnormal posture.
So for the ones with severe traumatic brain injury, you can have decerebrate or decorticate posture, decerebrate, decorticate posture, which tells you the level at which the brain affectation is unequal pupils and isocoria, which could be one of the features of raised ICP. And once the pupils are unequal, it might be a point that there is cerebral edema, which will eventually lead to raised ICP. That could be Cushing's reflex, bradycardia with hypertension, or Cushing's triad, when you have bradycardia, hypertension, and irregular respiration. Then if a child is unconscious and the level of unconsciousness is persistent, just know that something might be going on. Let's say a child comes in, even if they don't give you history of the child having sustained the trauma to the head, if you're treating malaria, cerebral malaria, or meningitis, meningoencephalitis, and all that, and you find that this child is still persistently comatose, it calls for cranial imaging for you to really know what is happening. That imaging may reveal the underlying reason why the child is still unconscious. Might be, intracranial hemorrhage that has kept the child unconscious. So this is this cerebrate posture, decorticate posture. You can see the picture. Decorticate, decerebrate. So that's what you find in severely traumatized brain, like we saw in the third case scenario. So let's just try and help us understand better when we say severe, when we say moderate, when we say mild, what do we mean? So that brings us to the classification of traumatic brain injury. So Dr. Prisca.
Traumatic brain injury can be classified based on 3 classes: by severity using the Glasgow Coma scale, by mechanism of the injury based on how the trauma occurred, and by the timing. That's when the injury occurred. The injury we see at the time of the trauma or the injury that follows on account of the trauma that occurred.
So based on there's the severity classification based on the level of consciousness could be graded into mild, moderate, and severe. So using the Glasgow Coma score or modified Glasgow Coma score when you're dealing with children, if the GCS is between 13 over 15, there's a score of 13 to 15 on a scale of 15, then you will say that that child had a mild traumatic brain injury, like we saw in the first case scenario. Often what leads to this mild alteration of consciousness is a concussion, minimal or brief loss of consciousness. That's what you find. So the concussion will present with a transient loss of consciousness from which the child just recovers from being a few minutes. So for in moderates, when the GCS is between 9 and 12, the consciousness is impaired, there could be possible focal neurologic deficit. And when you do a cranial imaging, you might find abnormal imaging that, there's some intracranial bleeding that may have compressed on some vital areas that will now impact on the level of consciousness. But for severe traumatic brain injury, there is prolonged loss of consciousness. GCS is below 8. The least you can have is 3. So when we say 3 to 8, it's not as if this one is better than 0, because you can't have 0. So when the GCS is less than 8, there's prolonged consciousness, prolonged unconsciousness. There is significant neurologic injury, like what you saw in the third case scenario. And these ones are at high risk of life-threatening conditions, like we saw in the third 30-month-old that fell off the balcony of a two-story building. So this is what we had accidental fall. Or we have a feeling that maybe the caregiver wasn't happy with the parents of the child and wanted to, take it out on the child. Two-story building, and that's a lot. How did the child climb to the balcony and
jump
down?
Months.
Well, so the essence of this classification by severity of GCS is to help us prognosticate. So from the class, we know those that may likely have a very poor outcome and those that will have good outcome. So from here now, good outcome, severe, very bad, poor outcome. So it will also help guide our clinical management. A child that fell off from two-story building is not somebody you just do watchful with like we did for the first case scenario. So you have to, admit in ICU because anything can go south, in the process of the child's management, as we did for the child. So this is just a tabular representation of the classification based on the level of severity. The GCS between 13 and 15 will usually present with transient loss of consciousness within less than or equal to 30 minutes. Then post-traumatic amnesia, a person may not know himself or herself, less than 24 hours of that injury, but after that, everything goes back to normal. Then the imaging, cranial CT will not show any abnormality. For moderates, that's the GCS between 9 and 12. The level of consciousness is usually more than 30 minutes, but doesn't last for more than 24 hours. Then the amnesia can be more than 24 hours, but within 7 days of the injury, you find that that's amnesia resolves. Then there's abnormal CT finding, moderate, severe, the loss of consciousness lasts more than 24 hours. Like the third case scenario, the child was unconscious for days, several days, was in ICU for 15 days. So the first week of the child's life, the child was unconscious. Of the child's admission, sorry, the child was unconscious, and recovery of consciousness was by the second week, around the 13th, 14th day. Then discharged to the ward on the 15th day. So post-traumatic amnesia lasts for more than 7 days. At least when the child recovered consciousness, it took a while before she was able to recognize the mom, and although the dad was a bit scared, was not coming around until when they, went back home. So when you find some of these things, you shouldn't be perturbed at all. It's some of the accompaniments. Then the CT scan of the child showed them a lot of, affectation of the left cortical areas. There were some injuries, also blockage of the CSF drainage. There was hydrocephalus as well. So that was why the child had to get the shunt, placed during the third neurosurgical intervention. So if you take a glance at this table, you find how to, categorize the different traumatic brain injuries that we also shared some of the presentations that we had.
By the mechanism of injury, understanding the mechanism of injury can help us to predict how the injury would progress and guide management. So a closed health injury, there's no skull penetration. The brain injury results from a blunt force, could be fall, a road traffic accident, could happen during sports. And there are two ways it will happen. It will happen when the head is moving and hits a stationary object, like someone falling from a ladder or that child that fell from the balcony, or it could happen when a moving object strikes the head, like a ball hitting the head or a brick or a baseball bat during sports. These are the ways a closed head injury could occur. An open penetrating head injury. In this injury, the skull and the dura are breached by an external object. It could be a gunshot, it could be a knife, it could be a stick, like we'll show you. And then we have an acceleration deceleration injury, which usually occurs during rapid movements, vehicular accidents, or like shaking baby syndrome. So there's rapid brain movement within the skull, which causes sharing of axons.
So let's look at some of the descriptions. For those of us that love football, in those that watch the Nigeria Benin match on Saturday, you saw Steven, using the head to score 2 powerful goals. Now, as he's not in that ball, these are the things that could happen. So we really need to, give him his flowers. It's not easy. It's actually risky. As a heavy object like this is hitting your head, there could be some, injury to the neurons here underneath the skull bone at that point. Now, when, the person can be stationary and gets hit by the moving objects, at high, velocity. The same thing happens here when these objects, but this one is blunt. This one is, there's actually an boom here when this, bar actually hits the skull at this point. Or it could actually be that the person, the individual, moved rapidly. Let's say somebody is running and runs onto a bar of iron, a stationary bar of iron. So unlike here that this one hits the head here, there will be injury here. But when this one happens, the injury is actually on the, the opposite side. The head hits here. The pressure is transmitted back to this place so that the brain material hits the scalp at the back. So this helps you. The mechanism of the injury helps you to understand what exactly has happened. Is the impact? Is the impact actually on the point where the the object hit the head, or is it following a coup? There's what we call coup counter coup, effect when there's actually that kind of rapid movement of the body. When you shake a baby, instead of the point where the baby lean forward, you can actually have the impact on the side. So this young child had a penetrating head injury. So we've talked about mechanism, closed, penetrating, or acceleration. This one talks about the acceleration. This one can be closed injury, can also be used to explain the acceleration injury. But this one is actually a penetrating injury. This is somebody's help, and the person was now trying to discipline the child for not doing the right thing. Use the stick to be hitting the child. So in the process, nobody knows the level of the child's calcium, whether there is phenotype, the skull might be very soft and all that. So in the process of hitting the child, can see the stick penetrating the child's skull. So this is a penetrating injury. On the other side of the skull, you have the brain substance, which this stick would have pierced. So it just tries to explain the different classification based on the mechanism of the injury. So let's now talk about the classification based on
timing. The classification based on timing helps us to understand disease progression and secondary prevention. So in primary injury, it occurs at moments of impact, and these are the skull fractures, contusions, lacerations that occur after the trauma, intracranial hemorrhages resulting from the mechanical forces. While the secondary injury develops minutes to days after the initial trauma and could be due to cellular, biochemical, or physiological responses, including cerebral edema, ischemia, hypoxia, or raised intracranial pressure. So knowing the types of primary injury or secondary injury that could occur would help us know how to manage patients, know how long it's been since the injury occurred, and know how to prevent the secondary injuries that could occur following primary injury.
Let's say, for instance, somebody presents to you now that there was a road traffic accident that happened a month ago, and the child is now presenting a month after with seizures, maybe focal seizures. Let's say following the road traffic accident, the child fell on the left side of the head and now presents with right focal onset seizures. So that should tell you that the mechanism of that seizure is not primarily from the RTA. It's actually some of these things that we've outlined here. Now, the initial trauma may have happened with contusion, avulsion of the axons and all that. But the pro-inflammatory cascade that the body tries to set in motion will lead to some cellular and biochemical, injuries that will now lead to cerebral edema, ischemia, hypoxia, raised ICP that will cause presentation. So if the person is presenting, you're targeting to sort out some of these things, not to now bother about checking whether there's intracranial hemorrhage, whether there is a skull fracture and all these things. But if the time the person presents is within a short time, usually the 7-day rule is used to know the problems that could be primary, because from the point of that injury to the first 7 days, whatever that wants to manifest from that primary problem would have manifested. Then anything that happens 1 week after is unlikely to be from the primary. It could actually be secondary, but it's not absolute. There are some slowly collecting intracranial hemorrhage that over time, when the pressure effect builds up, you then start seeing the manifestation.
An example of a primary injury is a concussion. It's a common traumatic brain injury that could happen. It is described as a brief, irreversible brain dysfunction due to trauma, and it's a functional, not a structural dysfunction. Its onset is rapid, following the trauma. There could be headache, confusion, irritability, drowsiness, poor attention, loss of consciousness, but there's usually normal imaging, and the children usually recover within 10 days. It will be slower. And when managing a concussion, it's important not to leave the patient alone, not to leave the child alone, because you want to monitor them and see if there's any neurologic failure that could occur following the concussion, and also avoid repeat injuries after the concussion.
Okay. So for the post concussion syndrome, after the concussion, you want to ensure that there are no headaches, there's no postural dizziness, there's no fatigue, there's no mood changes. Now, within the time of that impact, there may be nothing. But like the second case scenario, that the child, now kept having persistent headaches that were so severe that, it affected the child's normal activity. That's what we call post-concussion syndrome. It might last days to weeks. The child presented like 5 to 7 days after the injury, and it now continued even during the second week of the impact. So, in as much as we asked the neurosurgeon to see, it's not as if we were expecting that the child should go under the knife, but the need for bed rest, close monitoring, the need for us to monitor that the activity is, a bit graded, so that the child doesn't worsen whatever that was going on, and the needed support that the child, needs at the time, having him coming to stay and us monitoring was the way to go for post-concussion syndrome.
Another primary injury that could occur is a traumatic intracranial hemorrhage, which refers to the bleeding that happens within or around the brain caused by head trauma. It is common after falls, sports, abuse, motor accidents, and symptoms depends on which type of bleeding is occurring, but could include altered consciousness, seizures, focal deficits, raised intracranial pressure. CT scan is important for rapid diagnosis, and an MRI can be needed for further evaluation to show vascular injury. It is urgent recognition prevents the secondary brain injury, especially in intracranial hemorrhage. The types that we could see include the epidural hemorrhage. The hemorrhage is between the skull and the dura. In epidural hemorrhage is a brief loss of consciousness followed by a lucid interval and then rapid deterioration, because the space between the dura and the skull does not allow for expansion
of the area of the collection of the blood.
So the blood collection is rapid and its effects are seen immediately. In subdural hemorrhage, the hemorrhage occurs between the dura and the arachnoid matter. To refresh our memories, the layers of the brain, from outside to inside, we have the dura, the arachnoid, and the pia mater. So the subdural is between the dura and the arachnoid. Its symptoms, there's gradual onset of symptoms because in that space we have a lot of space for blood collection to happen before the pressure effects can manifest. So we have vomiting, irritability, seizures, and on CT scan, they all have their different appearances, which will be showing. Subarachnoid hemorrhage that happens when there's collection of blood in the subarachnoid space, known as causing sudden headache, thunderclap headache, worst headache of your life, photophobia, neck stiffness, altered consciousness. And then there could be an interparenchymal hemorrhage where there's a hemorrhage within the brain parenchyma, which causes focal deficit, seizures, and altered mental status.
Okay, so by way of pictorial representation, so these are some of the brain imaging that will show you what exactly is going on. For epidural hemorrhage, this is the skull. This is the connective tissue membrane between the inner part of the skull and the outermost covering of the brain. So this is the epidural space. You can see how limited this space is. So the more blood that collects here, the more it will impinge on the brain's substance, because there is very limited space for it to, track down to. For subdural, there is more space, for the blood to collect into. So the presentation here, the symptoms might actually be insidious, be gradual, not as sudden as what you find in epidural. But in subarachnoid, you've seen that it's actually tracking down into the, gyri and sulci. So you have more life-threatening presentations here, unlike what you find here and here. The presentation here might just be focal, reflecting the part of the brain that is impinged on, whereas this one can be more diffuse, giving you some life-threatening, features. This is a subdural hematoma. You can see this one is subarachnoid. You can see that it's actually tracking down into the, the gyri, sulci, and all that. This is epidural. You can see how localized it is, just impinging on this part of the brain. So when you do a cranial imaging, as these kids present, just look out for some of those features on the film. So if there's fracture like we had in our index, there could be a depressed fracture. We'll show you a picture of what a depressed fracture looks like. The skull is like a collection of flat bones joined together. The suture, there's what we call suture lines now. So when the skull bone, fractures and presses down onto the underlying structures, the brain parenchyma, you need to, push it back outwards. If not, the impingement will be causing, impairment of the functionality of that part of the brain that is affected. It can be linear, simple linear, fracture that doesn't present any displacement. So just manage conservatively. You don't need to do anything. But for depressed fracture, as we had in our third case scenario, a surgery needs to be done to, push back up the, compressed part of the brain. So this is an example of what a depressed fracture. Okay, so let's use this. There's an impact that fractures this skull here, but the skull bone pushes inwards, like you find here. You can see the normal outline of the skull, but there's an inward displacement of the skull bone here. So this is depressed fracture. Here you need to, the neurosurgeon needs to push back up the compressed part of the skull. So in linear, there's just a crack. One would wonder, if you're saying linear, why is it not? It's just that it's just a crack. There's no displacement, nothing, just a straight, a kind of crack like that without any depression. Diastatic fracture has to do with fracture that occurs along the suture line. There's sutural diastasis from a fracture of a traumatic brain injury. Then you see the two parietal, this is the frontal, this is the parietal bones on this side. The sutural line is separated at this point. So this is the aesthetic fracture. Basilar fracture is the one that's base of skull fracture, like you saw in the third case scenario. So when there is base of skull fracture, there will be raccoon sign, battle ear sign. There could be blood coming out from the, the orifices, the nose, the ear, and all that. Then that brings us to the red flags. If there is any traumatic brain injury and you find any of these presentations, please just know that it's a life-threatening traumatic brain injury that needs, emergency care. So, Dr.
The skull fractures, when you see them, the symptoms or signs, like you see a scalp swelling or hematoma, if you palpate the skull, there could be a palpable defect, vomiting, irritability, or as you said, CSF leak. The red flags, the battle sign, raccoon eyes, persistent vomiting. Battle sign is when there's a
erythematous patch around the ear.
The ear, yes.
The pinna.
And then raccoon sign is when it's around the eyes. Then persistent vomiting on the
eyelids.
We'll show it
in the picture, but it looks like. So whenever you see any of these red flags, please get a cranial CT done. So the cranial CT will help you know what exactly is going on. The collection that is going on, where exactly, is the intracranial bleeding, collection, or fracture. Then if you're thinking more of a soft tissue or vascular injury, MRI would not be the diagnostic. So if you're thinking of something more solid, blood collection, think CT. If you're thinking of soft tissue affectation, neurons, vascular affectations, MRI. But your basic physical, examination skills should not be trashed. You should always look out for these physical features, like this is the raccoon sign. Our third case scenario presented with bilateral raccoon signs. Then battle ear, you can see this erythematous patch around the ears. So this is a red flag that something untoward. There's actually fracture with injury, bleeding in the brain. Then this is a CSF rhinorrhea, CSF octuria, CSF rhinorrhea. So once there's CSF leak, just know that something, see clear fluid coming out. This clear fluid is not catarrh. This one that is unilateral is not allergic rhinitis. So once there's any traumatic brain injury and you're seeing clear fluid coming out either from the nose or from the ear, just know that it might be CSF leak that you're dealing with.
Okay, so the secondary injuries, like we discussed, these are injuries that can occur after the primary injury, does not occur as a direct cause of the trauma. It includes cerebral edema when there is swelling of the brain tissue after the trauma. There could be raised intracranial pressure, headache, vomiting, altered consciousness, usually managed with head elevation, hypertonic fluids, and ICU monitoring. Like our third case, she was in ICU for 15 days.
So most of the things that you do is just the things you do to reduce the raised ICP, elevating the head of the bed by 30 degrees, hyperventilation, use of 3% saline, close monitoring. Because if you're monitoring closely, you actually notice when there is a pushing reflex or pushing triad. If there is an isoporia, you know that something is really going on. So at that point, you do things that will help relieve the cerebral edema, so that it doesn't lead to further neuronal injury and sequelae. So that brings us to the management. So these are a whole lot of events that can happen during this secondary injury. Now, if there is ischemia, let's say a seizure following the traumatic brain injury, the more repeatedly the seizure happens, the more oxygen is deprived, the brain is deprived of oxygen, and that will lead to, that's the oxygen deprivation, hypoxia will lead to ischemia. That part of the brain that is not getting oxygen from repeated neuronal activity, because the more the hypersynchronous spikes, the more glucose and oxygen that part of the neuron will require. If the supply doesn't match with the metabolic events happening, so you can actually have ischemia, and that will lead to neuronal death. That will leave you with a neurologic sequelae that might not be easily reversible. Raised ICP, the more the edema, the more the brain tissue is compressed, the more perfusion, that's blood supply to this brain tissue, will not be impaired, because the brain, the skull, for children that are above 18 months to above 2 years, the anterior frontal would have closed. So any fluid accumulation, any cerebral edema will mean that compressed space will mount so much pressure that will now impact negatively in blood supply to the brain tissue. and that will, lead to reduced perfusion, will lead to injury, neuronal injury, and eventual manifestation of neurologic sequelae. If you look at the inflammatory cascade, pro-inflammatory cascade that can follow, whether it's meningitis, because meningitis will leave you. Most of the times when a child that had meningitis will have, motor deficits, a speech deficit, visual impairment, hearing deficits, because of the pro-inflammatory, cytokines and tissue necrotic factors that are released that will destroy all those pro-inflammatory cascade happening, will destroy neurons. And the neurons, that the neuronal deaths will now manifest as impairment of the functionality of that group of neurons. A child that had meningitis that ends up having cortical blindness because the neurons in the occipital cortex were destroyed in the process of that pro-inflammatory cascade of the meningitis. Abscess will compress a group of neurons around where it's collecting, compressing and causing injury and death. Depressed skull fracture, like we saw in the third case scenario, as the skull impinges on the brain tissue, that point where those brain tissues, are situated, will lose their function. There will be direct destruction, as well as deprivation of even the blood supply, and that is leading to death and impairment of their function. So even surgery, when you're doing brain surgery, and somebody that is not skilled does that, in fact, nobody should go and touch the vital centers if you don't have the requisite skills. So that can also cause some pro-inflammatory cascade that will lead to destruction of the neurons and all that. Metabolic and cytotoxic injury, excess glutamate. The more the glutamate is an excitatory neurotransmitter, the more excitatory, the more energy that will be demanded. The more, if the energy demand is not supplied, there will be energy failure and neuronal damage to happen. So that's why if a child is convulsing repeatedly, you don't just say, let's leave the child. The more the convulsion, every episode of convulsion, there will be cytotoxic injury that will lead to destruction, because the more the seizure, the more the energy need. If the energy needs are not matched with what the neurons are getting, there will be neuronal death. Post-traumatic seizures, cortical irritation, the brain, neurons are very, very, very sensitive. So that direct trauma can actually cause cortical irritation that will lead to seizures. So the more that happens, the more it will lead to neuronal injury, and this will now present with post-traumatic epilepsy, which along the line you now find that the child might also have further problems that would actually derive from what I have mentioned earlier. The more the seizures from the injury, primary injury that happen, the more the edema, cytotoxic edema, the more the disruption, the more the sequelae can have post-traumatic epilepsy, can have epileptic encephalopathy, loss of some of the milestones that the child had achieved because of repeated poorly controlled epileptic seizures.
Okay, so in managing traumatic brain injuries, we use our ABC, initial evaluation. When a child is brought to you and said, okay, this child had a brain injury, first thing we want to do is our primary survey, ABCs of resuscitation, ensure that the airway is patent and protect the spine using the cervical collar. We could also assess the breathing of the child and circulation, check for perfusion. Neurological assessments, we assess the Glasgow Coma scale. This can help us to classify the severity of the severity of the traumatic brain injury, pupillary response, like we said. It could also be an indicator to what type of injury is happening, or if to the severity of the injury, the level of consciousness, the child conscious, the child unconscious, and other focal deficits that could happen, like hemiparesis, like we saw in the third case vignette, or any other consciousness that could happen.
Okay. So I just noticed now that some people are complaining that our pictures were appearing, in two places, obstructing their graphs of the slide. So I don't know. Okay. So okay. The two most important ones, there is a traumatic brain injury, is an emergency. So your initial evaluation should include normal ABC, ensure that the airway is patent, ensure that the child is breathing, circulation, check for perfusion, if there is bleeding, whether the ones you can see, you clip off. If you do an urgent planar imaging and there is bleeding underneath, get a neurosurgeon on board to, try as much as possible to, do borehole and drain if the child is stable for that. So then the other important thing about, after your initial resuscitative measures, the next most important thing for you to do is to do a neurologic assessment, because that will help you classify. Like we had mentioned in one of the previous slides that one of the ways to classify the severity of a traumatic brain injury is by the use of GCS, that's the Glasgow Coma score. For young children, for infants, the modified Glasgow Coma score can suffice, where you actually put the important parameters and use it to, grade the traumatic brain injury into mild, moderate, or severe. So for the severe ones, you have to admit in ICU. You have to get all the experts on board and do the needful so that child also. There are places where a child that fell off a two-story building will not survive, like a death sentence, but we should be able to handle such presentations when they come, as long as we do the right thing. So pupillary response is important. This can tell you if there is, cerebral edema, for instance. And ischemia is one of the things, unequal pupils is one of the things that will tell you there's a cerebral edema. If you're managing a case of meningitis and there's an ischemia, know that there is cerebral edema and do the needful so as to, reduce this cerebral edema and the subsequent outcome of secondary, neuronal injury that can happen, for that category of traumatic brain injury. Level of consciousness, you wonder, we've mentioned GCS. Why level of consciousness? Now, the complexity of GCS, most times when different people score, they give different values, but there are simpler ways of, ascertaining the level of consciousness. You can use Blantyre scoring system. You can use AVPU. There's a scoring listing that is very easy. AVPU. A is alertness. If the child is alert, spontaneously opens the eyes and looks around, that one is A. It means that the level of consciousness falls within that A category. There is V. If the child is not alert, but responds to verbal responses, that's when you call the child and the child opens the eyes. That one is V. There is P. P is pain. If the child doesn't respond to his or her name, but when you inflict a nauseous stimuli like pinching the child or just pressing hard on the breastbone, the child opens the eye. That one is P. Then U is unresponsive. So if you do all those things and there is no response, the child is deeply unconscious. So those are the very simple things you can do that will make your life easy. Not to start as this cry is normal or abnormal cry. Is it appropriate cry? or inappropriate cry, you now, somebody might see a child crying, this one is a normal cry. Another person will say, this cry is not, a consolable cry, is abnormal and all that. So level of consciousness is another neurological assessment that can be done to ascertain a child's level of consciousness. Then focal neurologic deficit is very, very important. Is one surest way of knowing this impact that happened on the left side of the brain is affecting the functioning of the right, like the third case scenario we shared. Fell on the left, has a paralysis on the right. So it now guides you to know whatever you're doing, try and find out, what exactly is going on that left side. To also guide the neurosurgeon to actually know that this one, if they are thinking whether to go in or not, but there are focal neurologic deficit, we will always make them, see the need to go in and find out what is happening there. So the management modalities basically, let's not forget our history, but remember this is an emergency. Not when the child is rushed into the facility, you now start taking history. Start asking for the mother, age, sex, religion, Christian or Muslim and all that. This is an emergency. So the quick history you want to get is you want to, ascertain the mechanism of the injury. The fact, if they just tell you that this child fell from height, that one is enough for you to know, this fall from height means that there is, if there is a, close injury, depending on the height, if there is a depressed fracture, this one will actually impact directly on the neurons. Then the key symptoms you want to know about is the child vomiting, because vomiting can be an early sign of raised ICP. Seizures could be a pointer that there's actually some neuronal injury. Irritability is another thing that tells you there is some level of neuronal irritation. Then also look for signs of non-accidental trauma. If a child presents to you and what they are telling you is not agreeing with what you're seeing, like that child that had a stick on the head, if they tell you that this child was climbing mango tree to fetch, get a mango and now fell down, and you're seeing a stick, they fall, there's no, obvious sign of for maybe bruising and all that around the side of the scalp the child fell on, then you just have to know that it might be a non-accidental trauma. It might actually be, abuse, child abuse, or something. You see an infant that you just know there's nothing, but there are pointers that something is going on inside. You might just know that it might be from the shaking baby syndrome. And you now do the counseling, observe the child, and do the other indicated management modalities. Monitoring is very, very important. Vital signs, as simple as respiratory rate is the regularity of the respiration, the blood pressure, if there is hypertension, bradycardia, there's Cushing reflex. Just think of raised ICP. Neurologic status, if a child has a lucid interval, is talking gradually, tilts into unconsciousness, just think of epidural or subdural hemorrhage, depending on whether it's sudden or insidious. Then other signs of raised ICP like lethargy, like effortless vomiting, like Cushing's triad, papilledema, that's the tail end of it, and aberrant papilledema. So once you find any of those things, just know that the intracranial pressure might be released, and you do the needful in that regard.
So in your diagnostic workup, imaging is important, especially when you see like a closed fracture, a closed head injury, or you're suspecting a fracture or suspecting that there's hemorrhage. ordered to do a CT scan, and it's the first line for, like we said, for detecting fractures and hemorrhage. But if we are looking for soft tissue, vascular injury, or symptoms that were delayed, that happened days or weeks after the fall, we can do an MRI to check for soft tissue, vascular injury, or delayed symptoms. Laboratory tests, if indicated, a food log count, a coagulation profile, electrolyte glucose. This can help you monitor during the phase where secondary injury could occur, can help you monitor and prevent the secondary injury from coming. And a toxicology screen, if the mechanism of injury isn't making sense to you, or if it seems very weird, you can also do a toxicology screen to know whether what caused the injury, or if altered mental status is unexplained, to know if there was any substance involved.
And then substance abuse is something that can make some people present with some very, weird symptoms that are not adding up. Let's say you see somebody say, giving you painting the mechanism of his injury, not in keeping with what you're seeing. An adolescent and all that. Just think of doing a toxicology screen. Person might have taken something, and his Royal Highness at that point, and at that level of highness, marijuana. This one, there's one we call monkey tail. This thing, fermented weed, cloud, Captain J. So when they take those things, they can actually feel superhuman and want to do some things like jumping down, from the a skyscraper and all that. So if what the person painted is not, rhyming with what you're seeing, just the toxicology screen to be sure that you're not dealing with this in a substance abuser. But even if you're done treating and the person goes back to that same habit, the next couple of days they will come back. Maybe if the first one was mild or moderate, might now come with something more, life-threatening, like we saw in one of the cases.
So acute management of traumatic brain injury, like we discussed, stabilization. When person comes to you, if oxygen is needed, you give oxygen, because we've seen that hypoxia can increase the risk of having secondary injury. IV access, if there was bleeding, you want to correct that, you want to rehydrate, you want to give fluids, head elevation to reduce intracranial pressure. After doing your history, your initial evaluation, and checking your vital signs, if you suspect raised intracranial pressure, and elevate the head. Seizure control if needed. If there's any seizures, you can control seizures using anti-epileptics. And if there's any need for surgical intervention, the neurosurgeon can be invited. They could do an evacuation of hematomas, repair of press or fracture, like we saw in our third case scenario, and management of CSF leak, the basilar fracture that might have happened. The medications I give.
Severe medication. If you need to decompress, although this is controversial, use of monitor. If there's actually bleeding, if it's a primary injury with bleeding because of mass action, you are not expected to give monitor. Or if the cerebral edema is from secondary causes, cytotoxic injury and all that, you can actually give to compress. Hypertonic saline, 3% saline, which will also help to organize the fluid out of the brain parenchyma to the intravascular space so that the edema is relieved. If there is pain, remember the pain fibers, on the periosteum of the bones is very, 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 very sensitive. So a child that had a skull fracture will have very severe pain. So we want to ensure that there's optimized pain control. And you may want to sedate, because the more irritable they are, the more they try to move, can actually worsen some of the problems that they presented with.
So in traumatic brain injury, the ongoing care and follow-up, we observe and admit when you realize that this injury could be a severe traumatic brain injury or even moderate, you can admit for monitoring, and that's when you can do your imaging and see if it's normal or abnormal, ICU care if there's any severe injury, rehabilitation and support. Following the resolving of the traumatic brain injury, it's not expected that they just go back to normal immediately. They need to be slowly recuperated into their former lives or into society. So physical and occupational therapy is important. Neuropsychological evaluation could be done, and if in school accommodations, if cognitive effects persist, the school should be expected to accommodate them, understand what happened.
Okay, so they are still complaining about the slide, the pictures. You say there's another one, the lower part of the slide blocking participants from seeing. The one up has gone up, but the one down.
But what I'm saying is normal. When the person not doing.
Okay, so the IT team is suggesting that some people are not seeing that. So if you're witnessing that, just log out and log in back. That may not show again. Okay, so the other important things to do apart from the patient care and all is to educate the caregivers. Like that child that fell off from a two-story building. In civilized climes, the parents will lose the custody of that child, that 13-month-old child, because of what happened. So the caregivers should know that toddlers can do some of those things because there's no sense of danger. They should keep a close watch on their kids. And for the parents, they shouldn't just hire anybody to look after their kids. An adult that has been taking care of herself, that is not level-headed and well put together, may not be able to take care of a toddler. The person might be, on the yellow app, while the child has gone to, the road and all that. So the caregivers should be educated. Social services should be involved if you're suspecting child abuse. Like we mentioned that some of the traumatic brain injury could be non-accidental. So if you're suspecting a non-accidental traumatic brain injury, you need to involve the services of social welfare officers so that that child is protected from further harm, in the setting where he or she is in. Now, even when you evaluate a child with traumatic brain injury and everything appears okay, you should schedule further follow-up because from what we've seen in the presentation, there could be secondary injury, not from the primary trauma, from inflammation, metabolic abnormalities, and other things that will tend to leave a more long-lasting sequelae than even the primary problem itself.
The prognosis, what can tell us if this traumatic brain injury will have a good or bad prognosis, includes the severity of the injury, like the GCS score, like we discussed, image findings, the age of the child. Younger children have different recovery patterns and prognosis could be worse. The type of the injury, an isolated concussion has a different prognosis from a hemorrhage that had edema. Time to treatment, early intervention improves outcome. If the child was seen immediately after the trauma happened, compared to when the child was seen 7 days after the trauma happened, the prognosis is going to be different for those two cases. Some short-term outcomes that could happen following traumatic brain injury. Most mild TBIs have concussions that could result with rest. Moderate to severe injuries may require rehabilitation rehabilitation. Our third case scenario, required rehabilitation. Risk of complications like seizures, behavioral changes, or learning difficulties could happen as a short-term outcome following a traumatic brain injury. While the long-term outcomes following a traumatic brain injury, some cognitive, emotional, or motor deficits could occur. Some children may develop post-traumatic epilepsy as a secondary cause, a secondary injury following a traumatic brain injury. And for these people, early therapy and school support will improve long-term function, but there's a higher risk with severe and delayed treatment, and they all require neuropsychological follow-up.
So that brings us to we've talked about traumatic brain injury, what can happen, how to prevent, how to present, and what we should do as healthcare practitioners. Now, the other thing now is prevention. Every parent should know some safety habits that should be applied to the children. You don't need to wait for a child to fall off the bed or to fall off the balcony before you come to the hospital. Even ensuring that your children play, you don't leave your children to play by the balcony. Especially if the balcony doesn't have a child protective, cares that prevent a accidental fall, from height. So they should have a safe play environment where there is no potential, harm that can come to them. Then once you're seeing any child that you're suspecting an abuse, there are some marks you see on examination around the neck, around the anterior abdominal wall, and then, on the face and all that. That should tell you that this thing is not just, maybe you see old wounds, new wounds, when there are several wounds at different stages of healing, you might be dealing with a child abuse case, and that should be reported so that the child. I remember one of the kids we saw, some years back that presented with traumatic brain injury but recovered consciousness while in the hospital. So when we were examining, we saw a lot of wounds all over the body, and when we were asking, the responses we were getting weren't tying up. So we had to inform the child, is Ministry of Social Welfare and all that, to come see the child and follow up in the place where the child was staying. So by the end of the day, we were able to ensure that the child went back to the parents, because the parents sent the child to stay with the auntie who was abusing the child, to the point of instilling that trauma to the child that landed him in the hospital. So these are, real life scenarios that we can ensure that we put into play, that we can apply to our practice, so that our kids are safe. The injured child should be supported emotionally and academically. Now, a child that suffered a traumatic brain injury may not function at the same cognitive level, depending on the level of neuronal affectation. So any child that was doing well in school that is now struggling shouldn't be, stigmatized. Should get all the necessary support while we follow up and ensure that the child improves. Use of safety gadgets. There are helmets that toddlers in civilized country. Just imagine when we were learning how to walk, how many times we fell, whether forward or backwards. So nowadays, it's not enough for you to say my child is learning to walk on a cemented floor, and you leave the child to be falling on the head and say, it's part of the growth process. There are safety helmets that these kids can wear so that when they fall, it protects them from a potential, head injury. Use of baby car seats, safety gears can also help prevent that from happening. Okay, the caregivers should be educated on how to prevent, for births. A child should stay, an infant should, a baby should stay in a cot that has, protective rails so that the child doesn't fall off. Don't keep a child on your own bed and say you want to check something in the kitchen. So that child can actually fall off the bed, depending on how high rise, some of our beds can be a lot. If it's so high and the child falls down, it might be a problem. So you can actually maybe put a very soft carpet with foam. Yeah, carpet that has some, paddings, padded foams underneath that can, provide a safe landing for these children when they fall off the bed and all that. So we should be able to also, as we mentioned earlier, recognize signs of child abuse and do the needful to prevent further recurrence. So we believe that having listened to our presentations and discussions so far, and in line with our targets, we should have been able to, understand that traumatic brain injury is something that can happen. There are cases that can present to us. So although it's common for children to fall off the cot, fall off the bed, fall while trying to walk or play, it can be potentially serious. So our, level of clinical suspicion should be high when a child presents to us with altered consciousness. Just try and rule out possible traumatic brain injury and ensure that you don't just keep and manage. Bring in multi-disciplines aboard, like we did for that child that fell off the staircase. Pediatric, when we needed to secure central, and pediatric surgeon needed to come. The brain surgery that was done, neurosurgeon did it. So when multidisciplinary approach is applied, the outcome will be better. The child is undergoing rehabilitation now. And we should also ensure that we keep educating our mothers, our caregivers to be vigilant about their toddlers, because they can potentially have brain injuries that could be life-threatening. Now, if we're able to intervene early, as was done for all the cases, especially the third one, the outcome, the child's outcome will actually be very, very good as compared to when the intervention is delayed. Thank you for your time. I believe that you've been enlightened somewhat by this presentation. Thank you. I don't know if there are questions, so you can put them on the chat box. And thank you for listening in. Thank you. Okay, so while we wait for the questions and the comments on the chat box, we want to invite us to the Abuja the 9th annual Abuja Cardiovascular Symposium, ACS. This has become like a culture, for people that want to, come up to the current, want to get acquainted with the current trends in cardiovascular medicine. People from across the country, across the globe, converge in Abuja every year for cardiovascular symposium. It promises to be, inviting. Now we're using a bigger space at Rainbow Events Marquee, in Area 8, Gariki. It will hold between the 11th and 12th of December 2025. So clear your schedules, come and learn real life, stepwise systems for cardiovascular care. Every cardiac arrest is not a death sentence. You can actually do some things to save those lives in your facility. So what are the bedside inpatient basic life supports guidelines that you can apply in your different facilities? Just come and learn. You'll be surprised that some of the things that you found as gargantuan might actually be something that you can do one or two things to change. Advanced life, cardiac life support in every healthcare setting, be it at primary, secondary, or tertiary level. Just come and see what you can tailor to your patients in your place of practice. Then ECG, most people are very scared once they see ECG. Just come so that our seasoned cardiologists will demystify ECG for you, so that when anybody brings ECG, you can easily interpret it. So it's a very, very, very useful tool for every healthcare professional. You can use it to know some of the abnormal readings that needs some special attention. So just come Thursday to Friday, 11th to 12th of December 2025 at Rainbow Marquee, and improve your knowledge base and set skills in cardiovascular medicine. The registration is just give away, 10,000 for this kind of
information.
Wow. Okay, so you've seen it now. Just for all the number of things that you gain in this cardiovascular symposium, just 10,000 registration will offer you that your materials, the resource persons that you benefit from, the BLS, ACLS that people pay hundreds of thousands for. With 10,000, you'll be able to get those skills. Thank you. Let's see the questions that have been dropped in this slide. Okay, so someone asked, bearing in mind the shortcomings of GCS, how good is it in predicting the prognosis of TBI in children? Many thanks. Okay, so I had, I don't know the point at which Osundaja joined. We had mentioned the pitfalls of GCS. Different people will score different things, especially for children. Even with the modified Glasgow-Coma score, most times it's difficult to get uniform scores across different practitioners. So there are more practical ways of scoring. AVPU is what is used by most contemporary settings now. Alertness, verbal, response to pain, and unresponsiveness. So with that, those that have a better, level of consciousness, and those that have low level of consciousness. So you don't just use GCS alone. You also try to marry it with your clinical acumen. If the mechanism of injury tells you that whatever that happened was actually something very, very, serious. You don't say because the child is within this lucid, interval phase, you now leave them to go, only for the child to come back unconscious. So a child that is having, subdural hematoma may have, transient altered sensorium with a lucid interval. If you don't understand what exactly is happening, get a cranial imaging to tell you what exactly is happening. You might, be left with somebody that will present much later with more serious neurologic presentation. So we know that GCS is, is not very, very wonderful when it comes to, prognosticating TBI in children. So that's why you have to depend on your clinical acumen. The history is important, mechanism of the injury, the physical findings, then the imaging. When you tie everything together, you'll be able to know those that will require more than just, clinical observation and being allowed to go on. Those that will need surgical intervention, you do it early to have a good outcome. I don't know whether that helps the similar gem. That far? I suppose so. So, in the absence of any other question, I would, on behalf of Limi Hospital Group management, I want to thank all of us for making our time to join us again, today for this monthly webinar. Same time, same platform, and on the same thread. We expect you to join us, next month for an interesting topic on common pediatric cases that we've managed and that can help you out there in your practice. Thank you. Remember to register for ACLS. Just checking change 10,000. 10,000. Just like giveaway. So see you next month on this same trade. Thank you. Bye.
The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.